Hello, my name is Mustafa Al Haboubi, and this presentation was co-authored by Josephine Exley, Bob Aarons, and Nicholas Mays. We're all based in the Policy Innovation and Evaluation Research Unit at the London School of Hygiene and Tropical Medicine. This study is funded by the NIHR. The details are on the slide. In this presentation, I'll be giving a brief background to our research, the methods we used, as well as presenting the results and discussing them. In public health, contact tracing is the process of identifying individuals who have come into contact with an infected person to alert them of the risk of infection so that appropriate action can be taken. Smartphone applications can assist manual contact tracing by automating the process of identifying and notifying individuals at risk. Most of these apps use the strength of the Bluetooth signal to measure the distance between devices, but they differ in the location where the contact matching process takes place. In what is commonly referred to as the centralized model, this takes place in a central server that is run by a health authority, whereas in the decentralized model, the matching takes place in the handset itself. The main tech giants advocate for the decentralized model on the basis that it better protects the privacy of users. A number of governments around the world have deployed this technology to support public health efforts in combating the COVID-19 pandemic. In England and Wales, the NHS initially opted for the centralized model, but after testing the app developed on the Isle of Wight, it was found to not be accurate enough on all devices, and so a new app using Google and Apple's decentralized model was then piloted in the summer and launched towards the end of September 2020. The NHS app has multiple features, including tracing the contacts of the user and alerting them if they have been in close contact with other app users who have tested positive for coronavirus. It provides details of the level of risk at the postcode district level of the user. It allows users to check into venue using the QR code. It enables users to record symptoms and see whether they need to order a test. If they need to order a test, they can do so with the help of the app. And if they need to self-isolate, then they can keep track of the time left using the app. The NHS has recently started publishing weekly statistics on the use of the app as well as its activity. And from that, we see that the app has been downloaded almost 25 million times in England and Wales, with over 168 million venue check-ins being recorded by users. Unsurprisingly, both downloads and venue check-ins plateaued during the second lockdown before going up again. This sounds impressive. However, downloading the app does not necessarily mean that the person is actively using it. Also, it's much harder to establish the contribution of the app to the reduction of the spread of the infection. The research questions that we are going to focus on in today's presentation are as follows. How did the use of the app change over the first 6 months of the app's life, which coincided with significant changes in the pandemic? What are the reasons for downloading or not downloading the app? How does support for the app change over time? And finally, how do the characteristics of users of the app differ from non-users? This research is contributing to a wider evaluation of the NHS COVID-19 app that's being undertaken by the Department of Health and Social Care and NHS Test and Trace. To answer the research questions, we have so far conducted 5 waves of a longitudinal survey of an online panel of the survey organization YouGov. The surveys were conducted approximately every 5 weeks between October 2020 and March 2021. They included 2,023 smartphone users aged 18 to 79 living in England and Wales. Responses of the main sample were weighted to be representative of smartphone users in England and Wales. We also included a boost sample of 684 participants from Black, Asian, and minority ethnic groups. Surveys took about 10 minutes to complete, and the content of each wave was adapted to reflect changes on the ground. The retention of participants has been quite good, with 80% of those who originally started the survey completing Wave 5. Also, over 2/3 of respondents completed all 5 waves of the survey. Moving on to the results. We classified respondents as app users if they report downloading the app and entering their postcode details, which are needed to install the app. Overall, the majority had installed the app prior to Wave 1 of our survey, when the app was launched. Since then, the figures have been stable. This agrees with the data presented by the NHS. The number installing the app for the first time is small and has declined over the 5 waves of the survey. From the second wave onwards, the number uninstalling the app is marginally greater than for those installing or reinstalling it. We can also see that changes in restrictions over the course of 6 months of the pandemic seem to have little association with the installation status of the app. Finally, when we look at installation status by ethnic group, we can see that it was higher in the general public, represented in the top blue line, than in any of the minority ethnic groups, and was consistently above 50%. There was also heterogeneity in the pattern of installations. For example, in the Indian subgroup, it went up over the course of the 5 waves from 41% to almost 44%. Focusing on one of the main features of the app, the venue check-in, we can see a decline in the use of this feature over time in the general population, which coincided with the imposition of restrictions in January. It will be interesting to see whether the uptick in use observed in March continues in future waves of the survey. We asked respondents to identify up to 3 main reasons for downloading the app from a list. Looking at choices by age and gender, we can see that the 2 main reasons across the groups were firstly, seeing downloading the app as civic, public, and social responsibility to stop the spread of coronavirus and return to normal, and secondly, to let users know when they have been at risk. Looking at the reasons reported for not trying to download the app over the course of the 5 waves, it seems that concerns over privacy have declined over time. However, there was an increasing trend in reporting simply not wanting to use the app. The level of support for the app seems to be falling over time, with a majority of 55% being completely or somewhat supportive at Wave 1, but this dropped to 35% by Wave 5, while the percentage of those who are not at all supportive or somewhat not supportive has doubled from 16% at Wave 1 to 33% by Wave 5. Comparing the characteristics of smartphone users who had the app installed at all time points with those who never had the app installed reveals the following differences. The 2 middle age groups of both genders were less likely to have the app installed than the oldest and youngest groups. Also, those earning lower incomes, those with lower levels of education, those living in the most deprived and second most deprived areas, and non-white respondents were all less likely to have the app installed. In terms of health, those who didn't know whether they had contracted COVID-19 probably had it or definitely had it, were all less likely to have the app installed, as were respondents who rated their health as bad, very bad, or fair, those who felt they were limited a lot by a disability, and finally those who considered themselves not vulnerable to COVID-19 were all less likely to have the app installed. So, what do these results suggest? Firstly, the heavy restrictions in place over the time of our surveys could explain the little change in the use of the app. Hopefully, we'll be able to measure changes in future waves of our surveys as restrictions are eased. Secondly, it looks like concerns over privacy have declined over time. It will be interesting to see whether this trend continues. We have also identified differences in uptake of the app among smartphone users, which may increase inequalities in access to important information during pandemics, assuming that the app is effective in this regard. In the next steps of our research, we are going to focus our analysis on differences between England and Wales, as well as focusing on minority ethnic group respondents. Thank you for your attention.